All right, I'm back. Now we're going to do chapter 43, the liver, pancreas, and biliary tract problems. I am going to separate them into, first I'm going to do liver, and then we'll cover the other areas. So with liver, uh, we have hepatitis, which is really hepatitis, inflammation of the liver. But then, regarding clinical manifestations and problems and further complications, really depends on what type of hepatitis. The most common are the viral, A, B, C, D, or E. So that's the most common. Then drugs, alcohol. Alcohol is a big one when one is going into alcoholic liver cirrhosis, which is a complication of that inflammation of the liver. Chemicals, autoimmune disease is not as common, but you will see it, and that's when somebody has no other factors. Is hepatitis A, B, C, D, E negative, has never touched a drug or alcohol in their life, no chemicals at all, and they have some kind of genetic autoimmune disease. Some metabolic abnormalities. Now, complications to hepatitis, that's where the problems really occur, where you've got acute liver failure, chronic hepatitis, so some hepatitis B viruses, and most of the hepatitis C viral infections, cirrhosis, and then, of course, cancer. We're going to talk a little bit about the different viruses. Hepatitis A, that ranges from mild to acute liver failure. Hepatitis A is that virus that's transmitted via fecal or oral route, contaminated water, contaminated food. It's prevalent in socioeconomic disadvantaged areas, but of course the best for prevention is immunization and hand washing. Hepatitis B, acute or chronic. Now, the incidence has decreased with vaccination. So, for example, when I started nursing school in 94, I had to remember how old I was. In 1994, when I started doing my clinical rotations, that's when hepatitis B vaccines were mandated, and they were for people that had were in areas of risk, and healthcare workers were considered at-risk populations. So, but now hepatitis B mostly that's given through the CDC to babies and children. So the amount of people that are not immunized are getting fewer and fewer. Other at-risk populations, homosexual men, household contact of chronically infected, people going under hemodialysis, transplant recipients, or even blood transfusion recipients before 92, before they were screening for hepatitis virus. Hepatitis C, now this is the majority of hepatitis C patients develop chronic infection. Now, the high-risk persons, occupation exposure, dialysis, but the you can't really there's no immunization for it, so it's also difficult to detect. Screening is completed. It's if there's a blood exposure, especially for healthcare workers, one will be screened for it. And then again, patients be given blood or blood products before 92 That's also when hepatitis C was testing done for blood transfusions or are at risk. There can be a 15 to 20-year delay between when one is first infected to any clinical appearance of liver damage. Let's see, what else? About 30 to 40% of persons with HIV infected patients also have hepatitis C. So that high rate of co-infection is primarily related to IV drug use or the high-risk sexual behaviors such as homosexuality, the men having sex with men. Hepatitis, oh, and unfortunately hepatitis C, there is no vaccine, right? Hepatitis E and D can only occur if one has hepatitis B. So, sorry, let me backtrack. That's with hepatitis D. So, hepatitis D can only be replicated if one has hepatitis B. So the best prevention and the best defense would be to have the vaccine for hepatitis B. Then that's it on hepatitis D. Hepatitis E, transmitted via fecal oral route, occurs primarily in developing countries. Unfortunately, no vaccine for that, but that kind of works like hepatitis A. Clinical manifestations, so many patients are asymptomatic at first. Just like I said with hepatitis C, it could take 15 to 20 years before any clinical manifestations occur. With acute hepatitis, could have like the flu-like symptoms, the malaise, fatigue, and then, but if the liver is very inflamed, you may have hepatomegaly. For the acute phase of the infection, it can last from 1 to 4 months, and that's when you have those flu-like symptoms. There are really 3 phases of the clinical manifestation, so acute phase is your first. So for your acute phase of your physical exam to determine the diagnosis and the clinical manifestations, you're gonna palpate an enlarged liver. You may have lymphadenopathy. You may also palpate an enlarged spleen. The patient might be jaundiced and then with jaundice pruritus can follow, dark urine, light or clay-colored stools as the liver is not working right. Then with, let's see, the second phase, the convalescent phase. So the definition of that phase is when the jaundice starts disappearing, lasts weeks to months. So again, your acute phase, 1 to 4 months, and then your convalescent phase that can last weeks to months. Again, continued malaise, continued fatigue, continued enlarged liver. The spleen starts to go back to the normal size, though. And then finally, your last phase, the recovery phase. This phase, the patient can be reinfected with other types of viral hepatitis, different strains, but this acute phase, most patients can recover completely with no complications, and that's the clinical manifestations phases. For treatment, you have the specific antigen or antibody for each type of viral hepatitis. Your liver function tests are determining the damage of liver or how the liver is working. Viral genotype testing, so that's determining what type of hepatitis it is. Of course, your physical assessment findings. Liver biopsy, that'll rule out cancer. With the acute and chronic phase, you're wanting to maintain nutrition. You may have vitamin supplements. Avoid alcohol intake and drugs detoxified by the liver. So in your pharmacopoeia, that little mini pharmacopoeia, that has the little symbols next to the medication as to how it's metabolized. So part of your assessment is looking at the precautions of medications specifically for patients with hepatitis. With the hepatitis, adequate calories are important because of malabsorption or losing weight. Vitamin supplements, vitamin K might be frequently used if the patient is having problems clotting. If anorexia, nausea, or vomiting is occurring, that patient might be on IV solutions, or definitely fluid and electrolyte balance needs to be maintained. Counseling education for that patient is really avoiding the alcohol and that like over-the-counter medications or even herbal supplements that are detoxified by the liver. In addition, notification of any possible contacts to prevent spread of the infection. So drug therapy for hepatitis A, there's no specific drug therapy. With hepatitis B, only if severe and you're looking at the interferon. Patients with hepatitis C, interferon to reduce progression of the infection. And then, of course, for all of them, supportive therapy. For chronic hepatitis B, you want to decrease the viral load. You're trying to prevent furthering damage of the liver, so the patient will be taking interferon. Now, interferon has multiple effects of viral replication. There are two different ones. You're not required to really to memorize those. Just try to understand some of the side effects of this medication and really what they're for. So, for example, the side effects, if you're looking the side effect of neutropenia or thrombocytopenia, what are you monitoring? That's right. You're going to be monitoring the neutrophils, the white count, and platelets. Okay. What else? More drug therapy. These are just some examples of the therapy for chronic hepatitis B. Now, for chronic hepatitis C, it's individualized. It is based off of symptoms, viral load, and again, you can kind of be familiar with these medications, but you don't have to memorize them. Jumping back to health promotion for hepatitis A, general measures, there's vaccination. Before it was vaccination if you're going to countries where hepatitis A was prevalent. Now it is recommended even for children starting at 1 year of age. Adults receiving the vaccine. Let's see what else. The CDC is an excellent reference for the guidelines of vaccinations because they do change. Infection control measures. Isolation is not required, but again, it's the cleanliness. Now, somebody that's been exposed or there's known contacts, they might have a prophylaxis with immune globulin. Health promotion of your hepatitis B. These are the vaccinations, a series of the 3 injections. And then, of course, all children and at-risk adults. Hepatitis C, there's no vaccine, as I said. Screening all persons between 1945 and 1965. And then there's unfortunately, no post-exposure prophylaxis. So the CDC does not recommend immunoglobulin, but following an acute exposure, the person would have the hepatitis C virus testing done. For the person exposed, baseline and liver functions measured. But again, the CDC does not recommend immunoglobulin. Acute care for this hepatitis, you're assessing for jaundice, comfort measures, and again, just adequate nutrition, supportive therapy. In the acute care, physical rest, psychological and emotional rest, diversional activities to help the patient for symptom management. Most patients with viral hepatitis are cared at home unless they have the complications such as the cirrhosis or some other problems. So you're assessing for complications. So you won't see the patient in the hospital that is being symptomatically treated that can be cared at home. You will see the patient with cirrhosis, which is that chronic progression disease of the liver. Now the liver is one of our organs, so that can regenerate just like the skin. So with the cirrhosis, the cells are attempting to regenerate, but they become disorganized because there's the damage. So chronic hepatitis C, and in the U.S., the most common is hepatitis C and alcohol-induced liver disease. So those chronic hepatitis C, think of that at-risk population, maybe those with HIV as a comorbidity, or history of blood transfusion, IV drug use, and then the alcohol-induced liver disease. So those are two separate that you commonly see in the U.S. As precursors to the cirrhosis. Protein malnutrition is a problem. Let's see, what else? It's twice as common in men, okay? The goal of this treatment is to reduce ammonia formation. Ammonia formation in the intestines is reduced with lactulose. What else is lactulose used for? You guys may have seen it in the geriatric population to help with constipation. But the good thing about it is it traps ammonia in the gut, and then can help prevent or treat the hepatic encephalopathy, which is a problem with cirrhosis. So how are you diagnosing cirrhosis? The liver enzyme tests, total protein, albumin levels, cholesterol levels, the prothrombin time. Because the liver is disorganized, the clotting is a problem. Analysis of acidic fluid, so that's if a patient has ascites, and you'll see a picture of it in a second, in a couple slides. Treatment of the cirrhosis, rest, administration of the vitamins, avoidance of the items that can cause the liver to work harder, such as the alcohol, aspirin, acetaminophen, and NSAIDs. NSAIDs also secrete through the kidneys, so if there was a choice for extreme inflammation or headaches, one might use the NSAIDs before the acetaminophen. But both with the aspirin and the NSAIDs, the problem of bleeding can happen. encephalopathy, I talked a little bit about that. Ascites is a big problem where since the liver is kind of like a portal and kind of helps with excretion, it has a lot of blood going through it. So if it's not working effectively, the fluid, the perfusion is also not happening. So there's extreme edema, and ascites is where that fluid goes into the peritoneal cavity. This slide shows a little bit of the pathophysiology of cirrhosis. So when you print out this slide, if you just look at that, that just kind of reminds you of that pathophysiology. So clinical manifestations, so these are all the systems that are affected by the liver. Fatigue might be an early symptom, but later manifestations, the jaundice, the peripheral edema, ascites. So you want to look at this. You want to look at this figure so you can really understand each why each clinical manifestation is occurring. So we talked a little about the neurologic, the hepatic encephalopathy, anemia, thrombocytopenia, the spleen involvement. So take a look at that one. And how are you going to assess for each of these clinical manifestations? Neurologic, the mini-mental exam, metabolic, you're looking at comprehensive panel. This is a picture of what the ascites looks like. This is often treated by removal of that fluid. So you're looking at long-term management, beta-adrenergic blockers, repeated band ligation, portosystemic shunts that can help with patients who develop recurrent bleeding. The shunting procedures, they're used more for with that bleeding episodes, non-surgical transjugular or TIPS procedure, and that can also help with the ascites, with the peripheral edema as well. A diet for patient without complications. So these patients need high caloric intake, increased carbohydrates, moderate to low fat, but the protein restriction is really rarely justified. There's a school of thought that it might be appropriate in some patients who have hepatic encephalopathy. So it really just depends on how the patient is presenting. And then finally, for nursing implementation, because the patient is having fluid or perfusion, circulation problem. I know I said perfusion earlier, but I meant the circulating volume. Accurate intake and output is extremely important. Daily weight measures. Extremity measurements, so you're determining the edema difference. And then abdominal girth, so that also can give you a key on how much fluid is occurring. Okay, I'm done with liver. It's a little bit complicated, and I can address further questions in class.